For our program of work that we were working on, it was all about how do we really push the boundaries in reducing waits and delays. Previously, we'd looked at areas such as dermatology and diabetes, which are long-term conditions that have been improved in primary care settings, but we really wanted to be radical, really different in our thinking. So we chose urology, which is very different because normally a preserve for secondary care work and only done it in that setting. And the whole premise was, how do we look at that service, that arena, and really find a different pathway working to make a big, big difference to the waiting times for urology pathways. We had an ambition, a very big ambition, but we also wanted to understand that we had to take small steps to get to that ambition. The results, thankfully, were very, very good. We looked at a very basic concept of looking at existing referrals, how they were working in primary care before they go to secondary care. How could that be done differently? We managed to reduce the number of onward referrals to secondary care to be maybe about 20-30% as our first stage, which is great, a great start. So we kept on adding more and more to it. So we added more sophistication in terms of how the pathway worked between primary care and secondary care. We added diagnostics, we added a scanner within the primary care setting, and all of these things built on so our classic plan, do, study, act cycle. And we ended up getting to a point where 90% of the referrals coming in from a primary care setting were dealt with in that setting. So only less than 10% were going on to hospital and secondary care. So the challenges for our urology service were very typical of most change areas. There was a barrier in people just thinking, that's potentially overwhelming. That's potentially too big an area to look at. And that's how then we looked at how do you bite-size that and say, it's a trial experiment. It may not work. It may not work at all. And that's fine because there might be some learning that we could use. I think one of the biggest things that we learnt was that historically there is a great deal of variation between primary and secondary care. And that has a knock-on effect for both impact on referrals coming to secondary care that probably could be dealt with elsewhere, and also similarly work coming back to primary care that would find it difficult to deal with because it's outside of their scope in a way. So there is a way to fill that gap in a very robust way that can help reduce that variation, improve that flow for patients, reduce the referrals to secondary care, and also make primary care more effective in that initial referral journey, which is what is beneficial for them and patients. For it to be something that is done in urology, really, there's no reason that a lot more specialties cannot, be followed and adopted, being delivered in a enhanced primary care setting rather than secondary care. We are looking to spread and adopt the current work that we've done, but not just in urology. So we are working with various external stakeholders in NHS England, also within our own ICB, just to share the impact and the change that this particular pilot has achieved, using some of the approaches to ensure we've got strong quality improvement is really key, because it's going to help the people delivering that work to have the correct opportunity to maximize the limited time, effort they've got, but also, I think really importantly, help their resilience. Making change can be difficult, but be mindful that it will take time, effort, resilience, and some robust techniques and approaches.